Hi, I'm Dr. Robert Coffin, and we're about to go beyond the terminus. Many of us are seeing a lot more cracked teeth lately. While the origin of the increase in frequency is still under scrutiny, some think it has to do with our patients keeping their teeth longer, and there are increased numbers of teeth to crack. Others suggest it may be more stressful lifestyle contributing to parafunction. Some have postulated that the incorporation of fluoride into teeth while making them more caries resistant may have actually caused them to be a little bit more brittle and less flexible. The real answer is that we just don't know. The only thing we do know is that more and more patients are coming to us with symptoms related to cracks in their teeth. The most important questions we have to answer are the symptoms related to the crack? And if so, how far does the crack extend? And how does this affect our treatment plan? One important diagnostic tool is the transilluminator. In a recent lecture that I gave, I asked for a show of hands as to how many general dentists had a dedicated transillumination device. The response was surprisingly few. When combined with other clinical tests, transillumination is an excellent device to help us determine the location and extent of a fracture. The overwhelming number of fractures in teeth are mesiodistal in orientation, generally running through the central developmental groove. They can rarely be buccolingual or a combination of the two, but mesiodistal is certainly the predominant mode. The buccal cusps want to flex buccally, and the lingual cusps lingually, resulting in the crack. This can be seen even in virgin teeth, especially mandibular second molars and maxillary premolars. Popcorn is the number one killer. Hard candy and hard nuts, such as almonds, are notorious for causing these kinds of cracks in virgin teeth. Shining a transilluminator on the buccal or lingual surface results in blockage of the light along the fracture line. At that point, we move on to the pulp test to determine whether the pulp is responsive or not. We combine this with perioprobings to determine whether the fracture has resulted in subgingival detachment of the PDL along the proximal fracture surface of the root. Deep pocketing is not a good sign, and when it's combined with a pulp that is non-responsive to pulp tests or indications of furcation involvement, that generally indicates extraction is necessary. In cases where a single cuspous fracture is suspected, the tooth sleuth is used to isolate that individual cusp. In combination with the transillumination, we can sometimes try to see and determine the extent of the fracture and whether merely restoration rather than endodontic involvement is necessary. In many cases, a tooth surface restoration in one proximal surface leaves the unrestored proximal surface in a weak state. Occlusion in the central part of the tooth flexes the remaining cusps. We can often see a hint of this in the remaining proximal marginal ridge enamel. In other cases, such as in maxillary premolars and mandibular molars, one or more of the lingual cusps will be undermined by an MOD restoration, and it isn't long before one or both of the lingual cusps fracture off. Attempting to nurse such fractures by relieving the occlusion on them can provide temporary relief from the symptoms, but it risks having the fractures move deeper and eventually causing a subgingival cusp fracture, which often requires crown lengthening for proper restoration. Transilluminators can also be used after removal of restorations to see which cusps are weak and should be removed or shot. A couple of companies make them. I use the Microlux, which is generally available for around $170 US. Many years ago, somebody published an article in the Journal of Endodontics which claimed that bore sights, which are devices that are used to check the barrel of a rifle, could be purchased at your local gun store for about $10 and function similarly. All they are really is a light source attached to a fiber optic rod that is bent at a 90-degree angle. The light generated from the Microlux is stronger, but the bore sight might be an acceptable substitute if you are very cost conscious or you want something that is rugged and transportable. Lastly, you can try to light up the tooth with the fiber optic of your handpiece, of course with the burr removed, but I don't find it works as well as a dedicated device. Regardless of what you use to light up the fracture, it goes without saying that magnification, preferably with a surgical operating microscope, is the gold standard when it comes to visualizing the presence and extent of tooth fractures in the mouth. Diagnosing the extent of the fracture and ascertaining the pulpal status of the tooth are the primary determinants of whether we should attempt to restore the tooth and how. Transilluminator should be part of your routine diagnostic armamentarium. Remember, when we do the right thing for the patient, Not only do they get better, but we get better too. Join me on our next trip when we go beyond the terminus.